Okay, great. Awesome. All right, we'll go ahead and get started. And Pamela, are you able to? Oh, it looks like you've already started the recording. Oh, that's great. All right. So good afternoon, everyone, and thank you for joining us for today's webinar where we're going to discuss Modifier 25. My name is Jennifer Kastner Thomas, and I'm the coding director here at SENTA Partners. And thank you for joining us for today's session. Before we dive into the content, let's quickly go over a few housekeeping items. This webinar is being recorded, so we kindly ask that all participants please mute your phones and computers to reduce the background noise. To ensure that we're able to cover all material during our designated time frame, we will be taking questions related to the presentation at the end of the session. Also, the information that we're covering today is current as of today, and it may change with new information or clarification released by CMS, the AMA, or any of the Medicare administrative contractors. Any questions related to this presentation can be directed to me, Jennifer Kastner Thomas, at jennifer.kastner@sentapartners.com. During today's session, we're going to cover a few key areas related to Modifier 25 usage. First, what is Modifier 25? Next, when is it appropriate to bill an E&M service on the same day as a minor procedure? Followed by what is the difference between a minor versus major procedure and how it relates to Modifier 25. Next, what services are inclusive to a minor procedure. Also, at the end of the presentation, I have included a Modifier 25 checklist. And last, we're going to discuss a couple of clinical scenarios. To get us started, what is Modifier 25? Modifier 25 indicates a significant and separately identifiable evaluation and management service conducted by the same medical professional on the same day as another procedure or other service. According to Medicare guidelines, same physician refers to physicians and non-physician practitioners who are a part of the same group practice and share the same specialty. In such cases, billing should occur as if only one provider is involved. The purpose of Modifier 25 is to signify that the patient's condition necessitated an E&M service that was significant and separate from the typical care given before and after the procedure or the preventative visit in question. Claims contained in Modifier 25 are highly scrutinized. Therefore, understanding and adhering to these rules are imperative to prevent false claims. CMS considers a false claim a claim in which was not submitted based on coding guidelines, policies, and procedures. When we accept assignment with any insurance company, we are agreeing to adhere to their coding guidelines and procedures. Additionally, because CMS and payers publish their rules online for the general public to easily access, they have no mercy when it comes to us saying that we don't understand these rules. When additional E&M service is supported and meets the definition of Modifier 25, the modifier will be appended to the problem E&M code, which are your codes 99202 through 99205 and 99212 through 99215. All of our claims are submitted electronically, and not only does this modifier signify that a separate E&M should be paid, but it also prevents the claims from rejecting or denying the claim within their system. Without this modifier, claims will automatically reject or deny. Even with Modifier 25 on the claim, many payers still deny the claim because they want to see the documentation to confirm that a separate service is truly payable. This is why clear documentation is a must. If the scenario doesn't meet the Modifier 25 definition, then a separate E&M should not be billed, nor should Modifier 25 be appended. Additionally, the documentation must clearly support the separate E&M service. And I have a few examples in the upcoming slides that we're going to cover to further explain this. In this section, we're going to discuss Modifier 25 to understand when it's appropriate to bill the E&M service on the same day as a minor procedure. Before we get started, let's talk about first, what is the definition of a minor procedure? Minor procedures are characterized by low risk, minimal complications, and quick recovery time. CMS and payers have classified these procedures as having either a 0 or 10-day global period. Per CMS, generally a separate problem office visit isn't covered unless it meets the definition of Modifier 25, which again is separate and significant from the work associated with the minor procedure. Examples of minor procedures include like incision and drainage and the cerumen removal, to name a couple. On the other hand, a major procedure has a higher risk for complications and has a 90-day global period. Modifier 25 is never appropriate for these cases. And the only time an E&M should be billed on the same day prior to a major procedure is if an E&M service is occurring the day before or the day of, and it's related to the decision for surgery being made on one of those 2 days. And if it's appropriate, then that means Modifier 57 would be appropriate, not Modifier 25. An example of a major procedure includes tonsillectomy and septoplasty. When recording an E&M service alongside another procedure, the E&M should include efforts that go beyond the standard preoperative and postoperative care related to the procedure conducted on that same day. Physicians and other qualified healthcare professionals should be knowledgeable about the services bundled into a surgical package, as these should not be billed separately. The customary pre- and postoperative services linked with the procedure generally consist of the following elements and should not be billed using a distinct E&M service code. Again, these are inclusive to the minor procedure and should not be, these efforts should not be billed or included in the E&M code. These tasks include review of the patient's relevant past medical history, assessment of the problem area to be treated by surgical or other service, formulation and explanation of the clinical diagnosis, review and explanation of the procedure to the patient, family, or caregiver, discussion of alternative treatments or diagnostic options, obtain an informed consent, providing postoperative care instructions, and discussion of any further treatment and follow-up after the procedure. According to the claims processing manual from CMS, the initial assessment is always included in the payment for a minor surgical procedure. Any visits conducted by the same physician on the day of a minor surgery or endoscopy are integrated into procedures payment unless a significant and separately identifiable service also occurs. I would say out of all the slides, besides the little checklist that you'll find at the end of this, this is one of the most important because back in May of 2023, CPT Assistant finally released and clarified what is inclusive to a minor procedure. And these are the elements that they provided. CPT Assistant is a very authoritative source. They clarify a lot of industry questions and clarifications pretty much. So it's a very authoritative source and a lot of payers go by that guidance. To demonstrate that the E&M service was significant and above and beyond, the documentation should include the reason for the visit, additional or unrelated evaluation, development of a treatment plan or changes to an existing treatment plan, a unique diagnosis, although this is not a requirement, additional time spent, and the last one is medical necessity for both the E&M service and the procedure, because medical necessity is the overarching criteria for all payments. It's crucial to recognize that the E&M service could be triggered by the same symptom or condition that necessitated the procedure or the service. Therefore, having different diagnoses for the E&M service provided on the same day is not a requirement. It's easier to determine when something's significant and separately identifiable when it does have a separate diagnosis, but like it mentions, it's not a requirement, but there does have to be additional work there, even if it's the same diagnosis code. In order to bill an E&M on the same day as a minor procedure or a preventive service, make sure that the separate E&M service can stand on its own, meaning we should be able to carve out each of the services, as well as there should be documentation to support each of them. Remember, the work must be above and beyond the services that I covered in that previous slide that was clarified by CPT Assistant. Another recommendation I want to point out, if the scenario supports billing an E&M in addition to a minor procedure or a preventative visit, and you are coding this E&M level based on total time instead of, on the other hand, providers could use time or medical decision making to select a level of service. In the case where they're using time, we want to make sure we're not double dipping our time and that providers are only counting the time for the additional service. For each unique CPT code, there's work associated. The time is associated and integral to that. So, when we're using time, it's sometimes hard to tell, are providers including the time associated with the minor procedure? And because of that, I do recommend, just to prevent scrutiny, because time is money, and outside auditors, they often scrutinize things because they want things to go in the favor and the direction where they could hopefully recoup money. That's their goal, or prevent payment. So we want to minimize that scrutiny. So if the takeaway from this slide is if providers are using time to select that E&M level of service, you want to make sure to exclude the time associated with the minor procedure and only count what's above and beyond that. And I do recommend to have this verbiage within your note so it prevents that scrutiny. And this is just an example. And here on the slide, it states the E&M time mentioned within this note excludes any time associated with other billable services. Because again, an outside auditor, that's one of their first questions. They're going to be like, are you including the time with the procedure that you performed? So having this statement in there minimizes that scrutiny. Okay, so this slide addresses a common question. Can I bill an E&M visit for an allergy evaluation and an allergy injection on the same day? And this was a question that was posed on AAPC's website. At the end of the presentation on the resource slide, I do have the link to this so you could easily, refer to it. So AAPC's answer is typically the physician and allergist do not perform these services on the same day. More often than not, the patient will see the physician for an evaluation and management visit, get referred to the allergist for testing, or stay internal if it's the allergist that did that E&M. They render the service, and then the patient will present later date for an allergy injection once the allergist has the patient tested and develops the serum. However, in some instances, the patient may be receiving allergy injections and an additional evaluation is needed by the physician to determine the efficiency of the treatment or reevaluate the frequency of injections. In this case, it is appropriate to bill an E&M code with Modifier 25 because there's work above and beyond the injection that's occurring. In summary, documentation is going to be the key. The E&M service must be medically necessary, and the documentation must reflect that condition is being what they call the acronym MEET: monitored, evaluated, assessed, and treated. When these requirements are met, then billing a separate E&M visit would be appropriate. This slide addresses billing an E&M the same day as allergy testing and is a snip from the College of Allergy and Immunology website. In summary, when doing allergy testing, the test and results are inclusive to the allergy test. Anytime you order a test, whether it's a diagnostic study or whether it's a skin test, given those results is inclusive to ordering it. You wouldn't order a test and never give them their results. So part of ordering a test is giving them the results. It's not necessarily separately billable. It would not be appropriate to bill an E&M if these are the only services that are being provided. However, if the condition is also being addressed, where the provider is not only going over the results, but is also going over the patient's therapeutic options, risk and benefits of each option, and developing an action plan, then this is supportive of billing a separate E&M visit. Again, documentation is key. It must reflect this additional work. If a separate E&M is supported, then Modifier 25 will be required to be appended to the E&M, or else the claim will be denied. Also previously mentioned, unfortunately, many claims still with Modifier 25 are still denied because the payer wants to see the medical records as proof that a separate service is supported. So again, documentation is key. If that note isn't clear, then our efforts will result in a denial. On this slide, you can see where we pulled together a little checklist to help you identify when you could bill an E&M on the same day as a procedure. The first section says, do not bill an E&M if the answer to any of these questions is a yes. The first one, did the patient return to the office solely to have a procedure done because the physician did not have time to do the procedure on the day the condition was diagnosed? Does the note seem to be a recap of a previously taken history and plan? Was the minor procedure provided for an obvious, clear problem, such as a laceration repair or treatment for the impacted cerumen, etc.? If you answer yes to any of these, then you should not bill an E&M service. I do want to also emphasize, it goes the second one, does the note seem to be a recap of a previously taken history and plan? And what that means, if it's copied and pasted from that previous visit, then there may be a diagnosis that's medically necessary for the service, but was it really medically necessary to reevaluate them? I mean, if there's no additional work that's shown within the note. So if it's exact and it's just being copied and pasted, then there's really no additional work that's being provided because that work was already done at the previous visit. The next section says, bill an office visit with a procedure if you answer yes to all of the following 5 questions. Is the office visit documented? Is a procedure documented? Does the procedure have a 0 to 10-day global period? Does the documentation show more than the typical pre and post work associated with the procedure? Going back to that slide from CPT Assistant, that's what it's referring to. Again, all of those services are inclusive to the procedure, so we don't want to count those toward an E&M. And then the last one for a new patient is a separate exam documented. If you answered yes to all of the last set of questions, then you can bill a problem E&M visit with a procedure. The last section, we're going to go over a few common scenarios and a clinical example. On this slide, you'll see a clinical example provided by that CPT Assistant article that I referenced to previously that was released May of 2023. And where in this particular case, the scenario does support billing an E&M in addition to a minor procedure. And I do realize that this is not, an ENT or an allergy example, but this is a really good example that's an actual example from CPT Assistant. So I like the way they kind of, the scenario that they provided and their rationale for why it's supported. So I felt like it was a really good one to include. So looking at the scenario, this patient is an established patient with a growing lesion on the nose. In addition, the patient reports multiple enlarging growths on the back and dense scaly lesions on a bald scalp. A suspected basal cell carcinoma on the nose is biopsied using the tangential shave technique. In addition, the patient is reassured that the lesions on the back of the seborrheic keratosis that do not require treatment. However, the patient was diagnosed with diffuse scalp actinic keratosis, for which a cream was prescribed, and there was a treatment plan that was discussed. So the patient had that additional diagnosis of the diffuse scalp actinic keratosis, and there was a prescription. In this case, they're saying that you can bill the procedure for the biopsy, and you're also able to build the E&M code in addition to that because the multiple growths on the back and the scaly lesions on the scalp in which there was a prescription, all of that work is work that's above and beyond what it was totally different condition, first of all. So that makes it easier. But this was work that was not typical with the biopsy. So there was additional E&M work here that's described. Therefore, CPT Assistant has given the direction that this could be billed separately. Now, this is a clinical example, one of the ENT clinical examples that I pulled out of ModMed. And we can look at this at 2 different ways. First of all, let's look at the scenario here, how it's documented. The patient has nosebleeds. The HPI has some additional information, which is great. It's concise, but it does give us some more information. They've had several year history of persistent left-sided nosebleeds She has associated nasal crusting at times. She's not on blood thinners and denies aspirin use. And there were, of course, other things like a review of system, an exam that was documented. For the sake of space and time, I didn't include that because ultimately the impression and plan are also referred to as the assessment and plan. That's what ties it together anyway. We used to have to quantify history and exam and all that stuff. And back in 2021 and 2023, they changed all of that. So now we really, to help us determine a medical decision making, we only need like really the assessment and plan to really paint that picture for us. The other areas are still very important and a relevant history and exam is still required. It's just we don't have to use it for the quantification of auditing. So in this case, it looks like they cauterized for the nosebleeds. They cauterized it, and then there is a subsequent diagnosis that's listed here, chronic rhinitis, in which they talked about chronic rhinitis. They talked about the, relief, allergy shots, some different treatment options here. They decided to do saline sprays and over-the-counter medication management. So in this case, a 99203 and the procedure for the cauterizing of the nasal bleed, that both of them are supported because there's additional work here. This allergic rhinitis and the work associated with that is not something that's inclusive to the procedure. It's a totally different condition. Now, let's pretend like they didn't document this chronic rhinitis. And this is literally the only thing in the impression and plan or assessment and plan. In this case, an E&M would not be separately billable. And only the procedure for the cauterizing of the nasal bleed would be billable because there's everything that's described here, the informed consent, reviewing the problem area, expectations, the directions, post-procedure, all of that is going back to that slide from CPT assistant. All of those are services included in the procedure. So there's no additional E&M work here to put toward an E&M visit. So again, in this case, in this particular example, it is supported, but if they did not have the allergic rhinitis on there, then that 99203 with modifier 25 would not be billed and only the 30901. So this slide, here's our references. I want to point out that checklist that I went over, I can't get credit for that totally. I need to give credit to Betsy Nicoletti for that. She's over Coding Intel. I highly recommend you check out her website. She has a lot of free references and tools. There are some things that are locked and tied to a membership. However, she has a lot of free stuff as well. And I love the way she breaks down just about any topic. She's amazing. So recommend check out her website, but she's the one who pulled together that little checklist, and I got to give credit where credit's due. Other resources here, as I mentioned, I referred to a few different, questions and answers. And so you can find that resource, that reference material right here in these slides in one of these links. Okay, so now I'm going to turn it over to you guys to see if you have any questions. I'm going to stop sharing. And Pamela, you could stop recording. Okay, it looks like we have a question. Jackie, you have a